Good morning, everyone, and thank you, Rahul, for this wonderful program. And it's quite astounding the way you've organized this, and I'm really reliving the Zurich course here. And hats off to you for uh, continuing with the legacy of Professor Vallavanas. I was with them for quite some time, and he was the one who gave me the lead to go to the US and get further trained. And I can't forget that man. And he's no more with us, but his legacy continues through many channels, and Rahul is one of those channels. Thank you, Rahul, for this. Okay, I'm just going to share with you some of the knowledge I have about embolizing spinal dural AV fistula. Obviously, we all know the basics of spinal dural AV fistulas. It's the most common vascular malformation of the spine, and we deal with it. The most important thing we need to understand is understanding these dural shunts. This publication in 2008 from France, I think from Canada, describes the dural AV fistulas. It just bunches up the dural AV fistulas into three different categories. The one is the dorsal one, which is shaded in brown here. The dorsal one, they all have their own channels and they drain into the bigger venous channel, and they don't mostly come to clinical attention unless otherwise there is a block in the venous system. They all drain through either superior sagittal sinus, or in the spinal ones, they drain extradurally. They don't come to clinical attention. Similarly, the ventral ones, the ones shaded in blue, they all have their own venous drainage which runs ventrally, and they don't come to clinical attention. These fistulas we see when we do random angiograms, we could pick them up. Thank you. Whereas the ones which are lateral here, these are the ones cranially as well as in the spinal cord. They are the ones, they don't have their exclusive venous drainage extradurally, but they invariably drain intradurally. For example, if you see an ethmoid sinus, a middle fossa dural fistula, likewise the root entry zone dural fistulas, those are the ones that come to clinical attention because they drain into the medullary system and they compete with the normal brain venous drainage. And these are aggressive dural fistulas that needs to be treated. See, this is an example of a spinal dural AV fistula. This is an example of a ethmoidal dural AV fistula. This is an example of a middle fossa fistulas. They all come to clinical attention because they are aggressive and always they need to be treated. Okay. Obviously, you all know, I mean, you're all guys who do intervention. So the prominent clinical symptom is because of the venous congestion. The venous system gets engorged, and the spinal cord is generally a very, very low flow system. As Rahul was showing his little finger, spinal cord is as thin as this. Yes, the blood supply is very low. Their venous system are not robust like we see in the cranium. They are very small veins, and when they are congested to a certain level, they congest the spinal cord and come to clinical attention, and the progression is usually very, very slow, and they progress over a period of months. And most of them would have been treated elsewhere as transverse myelitis, as multiple sclerosis for many months before they really come to clinical attention. The radiologists have to have high clinical suspicion to pick them up and do the diagnosis. Evaluation, I think evaluation, one has to be very, very clear with the evaluation, and you need to do a complete angiogram. Obviously, DSA is the gold standard test. Positioning the patient is very important for spinal angiogram. You'll have to position in such a way, especially people who use biplane cath labs. You need to position the patient in such a way that you are able to use both the planes to acquire better image. For example, if you're positioning, you need to position with the arm either behind the head, or mostly I position with the arms raised up with the radiolucent stuffing under the elbow, so that the arm is not on the spinal cord, it is raised up. And the patient, you have to, if the patient is awake, you have to tell them that they'll be a little uncomfortable because the arm has to be raised so that your lateral plane can pick up the spinal column. Collimation of the intensifier. Most of the time I see spinal angiograms done at another center, they come to me with the CD. I see that they expose the whole area. You don't have to. The spinal cord is a very, very narrow space. You just need to expose only the vertebral bodies. Whatever runs over that, you don't need to see that at all. So to pick up a spinal vascular malformation or a vertebral vascular malformation, you need to collimate in such a way you see only that area and you can magnify it as much as you want. And a complete angiogram should be done. a complete angiogram, I mean, as Rahul was saying, the fistulas can be anywhere. So you need to look at both the internal iliacs, you need to look at the median sacral artery as seen here. You'll have to inject in such a way that you're able to include the internal iliacs, median sacral artery, and then each of the radicular arteries you need to catheterize and inject. Suppose one level you're not able to hook up, you need to inject strongly at the adjacent levels to see if there is a retrograde filling or filling of that level as well, because it may not always present at all levels, and you need to invariably see where your anterior spinal is. Before embolizing, just looking at the fistula, going after it, it's not the right thing to do. You need to always know where your anterior spinals are, and at the end of the procedure, I always recheck on my anterior spinal, I document that it's intact before I come out. So, and then you also understand your venous drainage, how far it goes. Okay, the challenges in treating the spinal dural AV fistula by endovascular means is that we are trying to fight a bar which is set very, very high. Because this disease has been treated as a surgical disease for a very, very long time, and the success rate is 90% or above. And if we are embolizing this, yes, we need to reach that level to be sure that we can compete, or we can say that this can be safely treated by this mean. So, obviously the paradigm shift has happened, I believe, because with endovascular treatment, our knowledge on this disease and the hardwares and the technical skills have improved a lot, and we are able to match surgical results today. So these are numbers between 2016 and 22, about 28 cases I've treated. So today what I do, when I have a patient who has possible spinal dural AV fistula, I take them to the cath lab with the intent to treat. We diagnose, if we are able to localize it and we are able to treat it in the same sitting, we just go ahead and do it, because that I feel is the most cost-effective treatment. If it is not treatable by endovascular means, obviously we have the backup of the surgery. Next day we go to the theater and do it. And I always use guided catheters for spinal dural AV fistula and NBCA. I have not used other embolic materials for spinal dural AV fistulas, and the choice may vary based on your experience. I'll just show you a few examples and the various scenarios we deal with, just for you to understand. There's a 58-year-old male present with paraparesis of 4 months duration, bladder bar dysfunction. The MRI and, this is the initial angiogram. Even before we find the initial angiogram, we always look for the artery of Adam Kevish. We find that, and then we go to the fistula. So this is the fistula. Catheterization. Catheterization is extremely important. The choice of the catheter for hooking up your vessel is extremely important. I mean, I use C2 Cobra for initial angiograms, and then switch over to SIM2 for embolization, because that holds well and you can hook it nicely into the branch. But there are other catheters, like Shepherd hook is a good catheter. I don't get it here, but Shepherd hook has a abnormal shape, like a Shepherd hook's handle, that can really plug into your segmental vessel. So Shepherd hook is a good vessel, but here I use Siemens 2 to hold it in position. And then your microcatheterization. Microcatheterization is what drives it. You need to get really closer to the fistula. Here, the microcatheter injection showing the initial venograms and then the venous outflow. So you need to get your catheter close to the fistula. In this particular case, as you can see here, this is the foot of the vein. Here is your fistulous connection. So you need to get your catheter tip as close as possible, as close to this network as possible for you to be successful. Unless you get this vein, this is going to recur. So here, this is my initial microcatheter position. I'm going to push it further. This segment of catheterization is extremely difficult, because the more you push more distally, your guiding catheter is going to kick back. You lose your current position. So you have to be extremely careful, always watch your guiding catheter and make sure that you're able to balance between the two as you push it forward. The most common thing, or the most interesting technique that works for me is generally put your wire. Don't put your wire because getting through these tortuous vessels is not possible with the wire. But with your flow-guided catheter, like a Magic 1.2 F or FM, you can push it forward ahead of your micro wire, and the micro wire can act within the catheter like an accordion. Like you get to one of the bends, which is the most critical bend, you just move it back and forth, having a positive pressure on your microcatheter, and your microcatheter usually flows through. Unless otherwise it's stuck in a branch or like it's stuck at a bifurcation point, it usually flows through. You don't have to get your micro wire all the way to the tip. So this is the final angiogram, and this is the glue cast. So if you form a glue cast like this, you are rest assured that this dural AV fistula is taken care of and you don't have to worry about it. This is an ideal situation. I mean, you may not get into an ideal situation all the time. I'll just show you a few examples. This is at the end of the procedure. So this is another patient, obviously a 46-year-old male alcoholic with a typical presentation, MRI showing the dural fistula, angiogram to identify the fistula, and then you look at the venous pattern as well, identify your anterior spinal, artery of Adam Keevish, and you need to catheterize and get as close as possible here. So here your fistula is right there, and your microcatheterization has been done, and if the vessel is large enough, you still can go further. So here we have catheterized even further, because there is not much of tortuosity in this particular case. NBCA mixed with ethidol was injected, and this is a nice glue cast. But you can see there is a little bit of glue going further. So when you're injecting glue, you need to control it. You need to watch both the reflux as well as on the venous side. On the venous side, as Rahul was mentioning, if it is fragmenting and flowing out on the venous side, you need to control your injection. You need to stop for a moment and then you need to inject. And when it starts refluxing, the usual technique I do is I pull a little bit backwards so that there is no further glue deposition when it's refluxing. You just have a negative pull and then pull the catheter back. Negative pull on your micro syringe. I usually use 1 cc syringe, not a 3 cc. So I give a little negative on the syringe and then pull the catheter back. That usually reduces the amount of reflux you have in the arterial side. So this is the glue cast. This is a young male who presented with progressive weakness of both lower limbs. Obviously, you identify the fistula, you identify your anterior spinal and its supply, and then you do a microcatheter injection. And most of the time, whenever possible, I try to do both AP as well as the lateral view. The lateral view gives you much more information. Yeah, this is a microcatheter injection and then the glue. As you can see here, there is a lot more things here. I have a microcatheter here. I have an additional vessel filling here. As I get the microcatheter more deeper, I see these dural branches. See these dural, there is a connection between the right and the left on the dura. These are the dural branches. We don't have to worry if this gets embolized, this is not going to the spinal cord. But we need to get more distal. So here I get more distal. I want this nidus to fill and this vein to fill here. But you see my glue cast. I have not gotten deeper. I've just gotten just there, but this actually is not the vein. If you see the previous angiograms, yeah, this is the one I'm filling, as you can see here, not the vein. So these are the patients when glue doesn't penetrate as you want, and then it starts reflexing and going into this dural connection network. If it fills like this, then you have to be cautious. You need to follow these patients very carefully. You can't be rest assured that he'll be cured, because initially the flow is reduced, the patient will get better, his weakness will improve, and he'll get all right, he may get discharged. But you need to ask them to come in about 2 to 3 months, do a check angiogram and see that the dural is gone and it's not filling anymore. There are chances that from the adjacent level, the dura can recruit more supply and these patients can recanalize. So this is at the end of the procedure. It looks great, but the MRI at 2 months looked good. I did a follow-up angiogram. The dural fistula was gone. Sometimes you need to be lucky than good. So this is another interesting case, a 53-year-old male who presented with a classic presentation of a spinal dural fistula, but this time the fistula was much in a different location than I thought. See, this is the injection of the internal iliac artery on the opposite side, and the fistula is right here over the sacral region. This is the venous drainage which goes all the way up, and the patient present with symptoms of dorsal cord syndrome. Practically at the dorsal level, the venous congestion was there. That was the presentation. So still, we can get through with these fistulas. We can superselectively catheterize. As you can see here, my microcatheter is here. I need to get all the way up here. The fistula is here. The vein is here. This is still the artery. So I need to get somewhere here to be safe that I can get to this vein here. I'll just show you the microcatheterization video. My wire is here, my microcatheter is here, as you can see here. You're having a positive on the microcatheter climbs, the wire is only acting as a little accordion. At this curve, I'm just allowing the microcatheter, facilitating the microcatheter to move forward. Okay, it has climbed up there, still not enough. I need to go further. This is the injection after that catheterization. You can see here, still this part of the artery remains. And there was a flow here. It was not a flow arrest. See, in this situation, there is one technique. If there is a stagnation of the contrast after you inject and stop, then this entire segment is plugged. As Rahul was saying, if it is completely plugged, then this segment of the vessel acts as an extension of your catheter. You can safely embolize and get your glue here. But if there is still a flow here, then you need to go further, because there is a good chance that you could embolize this part and the glue may not reach here. So you need to go further. Here our guiding catheter was in a good position, because coming in a retrograde fashion, my pushing out of my guiding catheter was not there, so I could even push it further. Yeah, here I got the microcatheter all the way up here. The fistula is here. I got the microcatheter all the way up and the wire is inside it. Oops. So this is the final angiogram. As you can see here, this is the fistula and this is the vein, and there is also an additional dural supply, and then the vein of that normal dura is here. So I know that the glue is going to fill both. It's okay, but I need to get here. So this was the glue cast. You can see here, it got into the vein. Once it gets into the vein, we are happy that this dural fistula is taken care of. So this was the final check angiogram. And obviously when we do the left, you need to check with the right side as well, the internal iliac, just to make sure that there is no collateral supply always. This was another young guy presenting with a dural fistula. Obviously you find your anterior spinal and you can see, and then the dural fistula you localize. Its venous drainage can be so extensive. The venous drainage is all over the spinal cord. There are situations where, if you have a good machine, you can take a good 3D image as well, which will give you a good understanding, 3D anatomy of how your catheter is going to move and how far you need to go. You can define your limits. You can actually define the fistula vein, the fistula, then the arterial segment. So if you go as close here, then you're good. So the 3D images are possible. So here we are getting closer to the fistula. And here I want to show you. See, my guiding catheter is at the origin of the vessel. I'm pushing the microcatheter here. I'm getting further down here, a little bit closer. I'm getting to this point, but you can see my guiding catheter is pushed backwards, which is not ideal to push any further. So you need to watch your guiding catheter all the time, because your leeway for losing your position is very high here. So here, I injected glue. And I think most of the situations, based on the flow, we mix the glue based on our instincts and with our experience. Here, the glue, I think, was a bit more dilute. You can see the glue flew up here. So that is not what I wanted, but we got the vein, but still, the glue was all the way up in one of the loops. Luckily, we keep these patients on heparin post-procedure, at least for 24 hours, and the patient did fine. So this gives you, tachycardia when you see this, right after your glue injections. And at the end of the procedure, obviously, always I go back and check my anterior spinal and then finish the procedure. Yeah, this a short video of the glue injection. I'll just show you. This is a routine dural AV fistula. With the C2 catheter, initial angiogram is done. Yeah, your microcatheterization is done. You get close to the fistula. Your microcatheter position is here. And you saw the reflux with the, I'll just play that again, sorry. Yeah. You need to get into the vein here. This is the fistula. So this is actual glue injection. Unfortunately, our machine stores only 248 images. I have injected the first portion of glue. I mean, actually, the initial glue went into the vein, and then there was a gap, and it started filling here. I leave a little gap, pause for a minute, because I've already got the vein, and then inject further again. As you can see here, I'm filling it again, deposit more, and then when a reflux comes, I pull back on the syringe and pull the whole thing out. So this is at the end of the procedure, both AP and lateral. Yeah, check on your anterior spinal and you're done. Okay, today when I would consider surgery, if I'm not able to catheterize, get closer to the fistula, if embolization fails, not able to get to the vein, I would consider surgery. There is another situation. If your artery of Adam-Kivi is arising from the same segmental artery, then you'll have to consider surgery, because you can't afford to have a reflux and compromise the spinal cord blood flow. So that is what I did here. This patient, conventional MRI or the classic MRI, as you can see here. Here the fistula is starting to fill, as well as you're seeing the radicular artery supplying the anterior spinal artery. In the later phase, not very well seen the anterior spinal. But the most important thing is you take a lateral view. It's extremely useful. You see the fistula here, you see the network of veins here. You see the radicular vessel, the anterior spinal artery is filling here. So that's exactly what you need to see. That's the importance of having a lateral angiogram in the spine. So if clump of vessels here, you may miss out on the anterior spinal artery. You need to watch very closely. That's why the collimation and magnified image is extremely useful. You have to inject multiple times to make sure that you don't have the radicular vessel arising from the same pedicle. And you can see the lateral view is extremely useful, and it shows you the anterior spinal arising from the same. I think Paritosh will talk on the surgical aspects, but I'll just show you a short video for this particular case. See, this is how the clump of veins appear during surgery. You can see the nerve root exit. You're just examining first, selecting out the arterialized vein there with the hook, taking it off. The anterior spinal artery is behind it. The artery, the radicular vessel supplying the artery of Adam-Kivi is behind it. It's optional. You can put a temporary clip and do monitoring just to make sure you're not getting into the artery of Adam-Kivi. But with experience, you know that you're getting the vein. So here I'm doing with the intraoperative monitoring, just do a temporary clipping just to make sure that I'm not compromising the spinal cord supply. The temporary clip is out. And then the procedure is actually fairly simple, cauterize and cut. You don't need to go about cauterizing the entire dura. If you take down the vein, everything will get cleared up. Yeah. And then you retract the whole thing, you see the artery of Adam Kivish here at the depth, which is going anterior to the cord. So, in my experience, I mean, obviously, of the 26 cases treated primarily endovascularly, we were successful in 24 cases, which is good. And 4 cases we have treated surgically, 2 primarily because the anterospinal supply was arising from the same pedicle, and 2 where the endovascular catheterization and embolization failed. And you can see that most of the patients improve. If they come early, they improve to become completely normal. At least a good number of them will be ambulant and get back to at least 80% of their normal level, because this is one rewarding disease in terms of success. So in conclusion, the endovascular embolization is safe, effective, and it's minimally invasive. It can be the primary modality of treatment for spinal dural AV fistula. You have to raise your bar up to match the surgical results, and surgical treatment is reserved for few selected cases. Thank you. Any questions?
Any questions from the audience?
The same question I want to ask that. Sometimes it's not feasible to go near the fistula and you have to be proximal. Then how to have a penetration of the glue up to the fistula? Because this is at least challenging for me. Difficult to go to the fistula, you are proximal, you inject the glue reflexes rather than going antegrately. So how to...
Correct, sir. So there are 2 things here. One is different people have different philosophy. I mean, and if I don't get close to the fistula, I would treat it surgically. I would go to the theater, open up and localize the point and treat it. There are some people, what they would do is they would inject a touch of glue, and they will go to the theater, because that glue drop will give them a localization during surgery. Radiologically, they can, with the C-arm, they can localize it. I mean, but I would prefer to just back out and then go to the theater and clip it or disconnect it surgically.
Dr. Rahul, any tips?
Rahul, any
push
thoughts?
the glue forward rather than...
Once he's done, I'll show some cases.
Okay, fine. That's okay. Yeah.
So I think probably this is that will be mentioned.
Yeah, I mean, you have to understand the anatomy, how the loop is, with the AP and lateral views, if possible, take a 3D and then understand the anatomy. And catheterization with the Magic 1.2 comes with experience. Okay, the Magic 1.2 comes in 2 configurations. One is FM and the other one is F. F has a long, supple segment, whereas FM has a short, supple segment. And the FM is the one that will work here in most situations. And you can, as we told, the accordion technique with the micro wire, 007 wire. Nowadays, I use the hybrid 007, and you use it as an accordion, not really putting it distal to the catheter. Keep it within the catheter, keep pushing, have a forward on the catheter, and just move your micro wire back and forth on the curve. Most of the time, it will push your microcatheter more distally. Absolutely. Absolutely. Always. After you embolize, you need to check at the level, one below, one above, and then your anterior spinal. Then only I come out.
Is there any bailout technique if inadvertently you were in jeopardy, you have embolized on the ASA? So what sort of salvaging mechanisms that can be employed, or is there any?
I mean, if you see, there are situations where people have embolized the origin of artery of Adam Kivish and they have got away with it, because anatomy helps you, because there are collaterals, especially with the additional radicular vessels, and they are supplying the spinal cord. People have gotten away. Unless you get to that loop and then actually embolize the anterior spinal, there are situations where you can get away with it.